and assistant professor in King Abdulaziz University, Jeddah. I'm honored and delighted to host this webinar. This is a series of webinars organized by the Saudi Society of Blood and Marrow Transplantation, led by Dr. Ahmed Al-Askar. Tonight's webinar is supported by Astellas, and thank you for their continuous and generous support. We have a very important and relevant topic on how I treat AML, incorporating measurable residual disease assessments. This is will be presented by our distinguished speaker, Dr. Pau Montesinos. Dr. Pau Montesinos is attending physician at the University Hospital La Fe in Valencia, Spain, where he also coordinates the research unit of the Department of Hematology. He earned his medical degree in the Faculty of Medicine of Valencia, Spain in 2000, and completed hematology fellowship at the University Hospital La Fe in 2005. Dr. Montesinos' main research interest is in the area of acute leukemia and stem cell transplantation. He was the transplant coordinator in hematology service from 2010 to 2016, and now leader of the acute leukemia program. He is a principal investigator of more than 40 trials from phase 1 to 3 in acute leukemias. He is also the co-chairman of the Spanish PETHEMA AML and APL group, devoted to clinical trial designs in acute leukemia, and carrying out an epidemiological registry of Iberian and Latin American AML-APL patients. Apart from clinical experience, he is leading translational biological projects of the PETHEMA cooperative group, setting up diagnostic biobank and laboratory centralization platform with harmonized procedures in Spain, and developing translational research projects in APL and AML. Being of special interest, the PCR, NGS cytogenetics, as well as flow cytometry. Dr. Montesinos authored 130 PubMed Index journal articles. He also published extensively on the treatment of leukemia in journals including Blood, Journal of Clinical Oncology, Hematologica, and Leukemia. So we're very glad and honored of having him with us. And the mic is yours, Dr. Montesinos.
Thanks a lot, Dr. Ahmed Marefab, and also Dr. Ahmed Al-Askar for this kind invitation and this kind introduction, so extensive, and also thanks to the Society of Hematology and Bone Marrow Transplant in Saudi Arabia, and to Astellas for supporting this meeting. So I will speak during the next 30 minutes about the management of, in particular, of relapsed refractory AML, but also frontline AML, and with paying particular attention to the clinical implications of MRD assessment during the patient journey in our times now that we are living in the therapy of AML, with novelties not only from the therapeutic point of view, but also and probably more relevant now, or still more relevant, the knowledge of etiopathogenesis and implications of minimal residual disease. This has become a tool in the clinical practice, as we will see now. This is supported by Astellas Pharma, as you know. These are my disclosures, and we will see now through a clinical case several implications of MRD assessment, and also in the therapy of our patients in this new era of targeted therapy, and with where we need clearly to dissect the disease diagnosis in order to offer the best therapeutic option to our patients. So this is a male patient, 34 years old, no relevant antecedents. With this age, it was a patient originally from Morocco that was living in Spain. So this patient was diagnosed in the emergency room with acute myeloid leukemia with blast cells in the peripheral blood. So he was immediately admitted at hospital. And so now, nowadays, one thing that we want to do is to deeply characterize acute myeloid leukemia regarding the molecular profile. It's not only cytogenetics like 15 years ago, but with the eruption of new molecular markers, we will pay attention to all these mutations, and some of them are very frequent, like FLT3 or IDH or the NMT3. This is NGS project from the Spanish PETHEMA group in 823 patients, unselected subjects, so not only patients treated with intensive chemotherapy. So this is let's say a real life cohort of patients who prospectively were included in this protocol that is still active and enrolling. And just in fact, the majority of the genes that are here captured with these NGS panels are genes that have been, let's say, discovered or incorporated to the molecular landscape of AML in the last 5 to 6 years. So this is a really very novel molecular information on our patients. However, FLT3 or NPM1, they are well known since more than 10 years, especially FLT3 since already 20 years. The first manuscripts showing the clinical impact of FLT3 mutations were published in the early 2000s. And it is important that this series that I'm showing here is representative of an overall population of AML, not younger patients like in other studies, like the study by Papa Manueli that was a series, a repertoire of a series of patients with NGS performed from clinical protocols. So younger patients, mostly, that were treated with intensive chemotherapy. Here we can see the cohort of patients younger than 65, so usually treated with an intensive approach. And we can see how NPM1 or FLT3 are the most frequent mutations, and we can see this 29-30% of FLT3 positivity or NPM1, that is what is usually said, no? The frequency of these mutations. But when we go to older patients, you can see here how NPM1 and FLT3 mutations are decreasing in its relative frequency. In contrast, other mutations like IDH mutations are more frequent in older patients. Also RANKS1, TET2 mutations, TP53. So especially those mutations that are correlated with clonal hematopoiesis and also with prior myelodysplastic syndrome, for example. So just to keep in mind that the molecular profile looks clearly different between older patients and younger patients. And we should put in context always regarding the prognosis and the AML characterization, the characteristics of the patients, age of patient in particular. This is the manuscript that was published in New England Journal of Medicine in 2016 that probably all you know, by Papa Manueli and colleagues. And they showed by deep sequencing, by next-generation sequencing, how gene fusions, that this was already known, translocation 15, 16, inversion 16, these gene fusions were correlated with the prognosis, but they relevantly showed that we can classify AML according to molecular, some variant mutations of NPM1 or IDH2 or CPA allelic mutations in particular, or TP53, and they state that there is a chromatin spliceosome group with poor prognosis. So this is a very relevant manuscript, of course, that is showing that all these novel mutations that have been incorporated since 2010 and on in AML landscape, they have relevance. But keep in mind that this is applicable, or these curves are applicable for patients that are treated with intensive chemotherapy approaches. However, the therapeutic landscape is switching, is shifting in AML. For example, in other patients with venetoclax and hypomethylating agents, or in younger patients with incorporation of targeted therapies. So I always say that the first prognostic factor is therapy itself. So these prognostic markers are dependent of the therapy that is given to the patient. So probably what is valid nowadays will not be valid in few years. One example is translocation 15, 6, 17. Acute promyelocytic leukemia was the worst acute myeloid leukemia subtype 30 years ago, with 80% or 70% of early mortality, and now is the most curable subtype of AML, and this is due to therapy with differentiating agents, as you all know. We can see in this slide the clinical relevance, the prognostic relevance of FLT3 mutations, in particular FLT3 internal tandem duplication, has been consistently related with an increased risk of relapse. And we know that with higher allelic burden of FLT3 mutant clone in AML, we will have worse prognosis. However, the prognostic significance of FLT3 TKD mutations, point mutations, are not clearly defined. Some manuscripts showed that could be related with worse prognosis, with hyperleukocytic leukemia, but others never showed this worse prognosis in FLT3 TKD mutated AML. So in general, we are not giving importance to this mutation regarding risk stratification, but nowadays, of course, it is a relevant mutation because patients can benefit from the beginning in the front line of first generation FLT3 inhibitors in combination with 3+7. This is the FLT3 signaling pathway. We can see here that the FLT3 receptor is a monomer in its unactive configuration, is a monomer in the membrane, and through the FLT3 ligand, when this is linked to the receptor, there is a dimerization, and there is a shape change in the tyrosine kinase receptor when there is this dimerization, and there is a phosphorylation, and then we can see here all the signaling downstream cascade. In particular, it is relevant the RAS and the JAK-STAT pathway activation that is giving survival and proliferation advantage to leukemic cell. But we should not forget that there is also the PL3K pathway activation that is inhibiting apoptosis when there is an active phosphorylation activation of the FLT3 through ITD or TKD mutations. So our patient, we come back to our patient. Of course, there is still, and this will never change, I think, the first approach that is morphological and even immunohistochemical or cytochemical diagnosis, and this is a 81% blast monocytic leukemia And cytogenetics is very relevant. This patient, after 2 or 3 weeks, will receive in our institution the karyotype with the trisomy 6, that is an intermediate risk. But now we require in the first week to have this mutational landscape of this patient, and we have NPM1 negative, and in that case it was FLT3 ITD positive with a low allelic ratio, 0.31. Was TKD negative. The commutation is very rare to have ITD and TKD commutation in AML patients. So once we know this molecular status and genetic status of the patient, we started before with the 3+7, but we rapidly have this with diagnostic workflow, and we started 3+7 therapy combination with midostaurin. We follow the PETHEMA protocol, the PETHEMA guidelines that were ongoing at that time. And this patient was characterized according to cytogenetic and mutational status. It was an intermediate risk patient. So again, we use MRD also to discriminate the risk, the relapse risk of the patient. We are not only standing, but this is in the context of a protocol, okay? We are not only standing on cytogenetics and molecular profile, especially for intermediate risk patients. It is very relevant to have the MRD assessment, and this is performed at the local lab in the PETHEMA group. Is a local assessment, and this patient had a positive minimal residual disease at 0.1%. That is this is the threshold that is recommended by ELN now, the recent revision 1 year ago. But this was the threshold that we were using since 2010 in our protocols, and this was a positive MRD flow in the bone marrow after the first consolidation cycle. We stand, of course, on the risk assessment, on the ELN classification, and as I said before, this was an intermediate risk patient with a low allelic burden NPM1 wild type patient. So what to do with this patient? Of course, we were following our protocol, and our protocol says that MRD positive in intermediate risk patient should undergo an allogeneic stem cell transplant. But if you don't have a national guideline or an institutional protocol, you can rely on guidelines, like, for example, European Leukemia Net. And this is very similar to the recommendation of the US NCCN guidelines. And for intermediate risk patients, younger fit patients, in this case, what is recommended? Whatever you want. Let's say you can do an allogeneic stem cell transplant, you can give consolidation with high dose or intermediate dose RC, or even you can give an intensification with autologous stem cell transplant. So as I mentioned before, in the PETHEMA group in 2010, we decided that risk stratification for intermediate cytogenetic and genetic profile patients, this stratification will rely on MRD assessment after induction. So this patient was planned to perform an allogeneic stem cell transplant. So we were calling his donor that was in Morocco. So we were doing all this administrative paperwork to allow the donor to come to Spain. Was a matched sibling donor, so everything was very fine, and consolidation was given in the meantime. And unfortunately, when the donor arrived and the patient was performing the pre-transplant workup, we found an early relapse with 34% blasts in the bone marrow at this stage. The patient was asymptomatic. So in this situation, what can we do? No, the patient has the donor here, but he has a relapse, and it's a FLT3 positive patient. We have some therapeutic options, in particular with second generation FLT3 inhibitors. So what should we do with this patient? We have in mind, and by our experience, not only publications, but we have in mind that AML is a heterogeneous disease, is a disease with clonal evolution, and the leukemic cells are sensitive to pharmacological and chemotherapeutic pressure. So therapy can make changes in the disease characteristics. And we have here an example that this was published in 2013, a study by the German group in a limited cohort of patients, of 50 patients approximately. And they study the clonal evolution model in NPM1 mutated patients. They selected this disease because NPM1 is a very stable mutation. So you can follow in this cohort of patients the different patterns of clonal evolution, always taking as a starting point the NPM1 mutation. Here is the red cross. So they studied a cohort of patients, about 50, and they see that comparing primary diagnosis and relapse, there were different patterns of relapse with the identical clone, with or without evolution, or an ancestral clone with less mutations that at the primary presentation, but not with an unrelated clone in the case of NPM1 disease. We can say that if there is a relapse with an unrelated clone, we can even say that this is not a relapse, it is a secondary acute myeloid leukemia, no? But this is a philosophical question. This study also showed with numbers the stability of different mutations in these NPM1 mutated patients. And we can extrapolate these findings to general AML population, although there is still a lot of evidence to generate in this field. And we see how NPM1 is a stable mutation, also DMT3, that is, let's say, a pre-leukemic or clonal hematopoiesis mutation. But we see here how FLT3 TKD mutations were not stable at all. Only 9% they have at relapse still the TKD mutation, and FLT3 ITD was also low stable mutation, or in sometimes was acquired at relapse. So keeping this in mind, it is very important. Even if we had only 3 months elapsing from the primary diagnosis and primary treatment to this early relapse in our patient, that it is worth to repeat the molecular assessment and characterization in the bone marrow of the patient, because things may change. And we repeat it's just impress. So you can find maybe in PubMed this article by the PETHEMA group with these 850 patients, and we reproduce the results of the German group showing instability or relatively instability of FLT3 ITD and also FLT3 TKD mutations between this is diagnosis and relapse patients, and this is diagnosis and resistant patients. And we see how these cells are showing changes in FLT3 status between diagnosis and relapse or resistance. So we can extend the recommendations from the European Leukemia Net to perform this rapid testing at diagnosis to have FLT3, ITD, and TKD mutations with or without allelic ratio in the first three days since diagnosis. We can extend this indication probably to relapse refractory patients. And this is what we are doing. It is true that in Spain, we have been doing this in the context of clinical trial because we had available clinical trials. For example, the Quantumar trial or the Admiral trial were available at the time of this patient, for example, for the treatment of relapsed refractory patients. So we incorporate in our therapeutic strategy to perform this retesting of FLT3, and in general, even all the NGS is performed at relapse or resistant in our patients. So this early relapse patients was retested. FLT3 was positive at a higher ratio that at the primary diagnosis. IDH was also tested because at that time we had a clinical trial with IDH inhibitors in the relapse refractory setting. The patient was negative. So What about this patient now? Is this a good prognosis relapse? I think that there might be some good prognosis relapse, especially late relapses after 1 year or after 18 months with normal karyotype or translocate or inversion 16. We know that these are late relapses or good prognosis relapses that can have a good overall survival. But we have two recent studies, one by the French group and other by the Spanish PETHEMA group, showing that the FLT3 ITD mutations are an independent risk factor for lower survival in patients with the first relapse refractory episode of AML. This prognostic factor at relapse was not analyzed in the 2005 study by the Ovon ERTC group, who defined this prognostic model. This is a different prognostic model for relapse refractory patients. And here you can see how we can discriminate the survival of patients according to these different markers. So I also would like to say it is important that the relapse refractory patient is not a patient where everything is done and the prognosis is so bad that it is not worth it to treat the patient. I really don't think so. And apart from these prognostic scoring models, for example, the Spanish one, this is for only specific for FLAG-IDA salvage. We can see that this is about 1/3 of patients. They will have, with the appropriate management, FLAG-IDA followed by allogenic stem cell transplant mainly, they can have more than 50% overall survival. So it is not true that everything is done once the patient is relapsing. This is another study recently published 2 years ago by the German group, and they studied in almost 800 patients the prognostic factors at the primary refractory disease. So this is not at relapse, but it's focused only on after one induction failure. And they found again that FLT3 ITD mutations are an independent adverse prognostic factor defining worse survival. Interestingly, in this study also, IDH1 mutations showed an independent adverse prognosis. And in this study, they were able to show that even the ratio, more or less than 0.5, could also prognosticate the outcome, the long-term outcomes of patients at the primary refractory episode. Also, they analyzed the impact of performing an allogenic stem cell transplant, and it looks, as we all know, that it is better to reach a complete remission and then to perform an allogenic transplant. And you can see here that more than or around about 50% of overall survival can be achieved in these primary refractory patients. But also, apart from these prognostic score systems, we know that MRD can be very relevant to define the outcome at relapse and especially before an allogenic stem cell transplant. This is a manuscript that had a lot of impact by Araki and colleagues, showing how patients with minimal residual disease detectable before allogenic stem cell transplant had dismal prognosis and similar dismal prognosis than patients that were allografted with visible disease, with morphological disease, 5% or more blasts in the bone marrow. But I would say that this is not clearly well defined. I think that we have different studies. Some of them, they do not show this clear impact on the prognosis, and it is probably not the same to have a 0.1% or to have 0.01 or to have 1%. So it is clear that the disease burden might influence the allogenic stem cell transplant outcomes. So what to do with this patient? We know that we need to give therapy and then tried to perform this allogeneic stem cell transplant that was planned with the matched donor. But what can we give to reach the best survival? The best survival, it is not clear that this is a meta-analysis that was performed by a colleague in my hospital. We see different regimens: FLAG-IDA, clofarabine-based, the amsacrin, MEC, and all of them, they are showing by the end similar overall survival around 8 months. Also, the complete remission rate can be also relatively poor, and this bar is not appropriate. This is like a 50% of complete remission, and we can see, however, that MEC or FLAG-IDA or even regimens based on Mylotarg, like this one, they can have a slightly better complete remission results than others. But by the end, the message is that the relapse refractory setting is a situation where we need investigation. We need to improve, because outcomes, short-term and long-term outcomes, are really dismal. So we believe that the best indication in this population is to include in a clinical trial. Of course, unfortunately, clinical trial is not available for all sites, so this is unfortunate, but this is how it is. That's how it is. And fortunately for this patient at that time, we had an open phase 3 randomized clinical trial that was experimenting with an oral FLT3 inhibitor, second generation FLT3 inhibitor. The patient had the concurrent medications, isoniazid and ciprofloxacin, and with second generation FLT3 inhibitors, it is needed and also first generation like amidostatin, we need to monitor QTc, because there is a risk of QTc prolongation, and this was a clinical trial inclusion criteria to have less than 450 milliseconds of QTc. This was done, and the patient started. This was an outpatient management with the pill. No problems during the first 3 cycles, no relevant. The patient was admitted by fever, but really not very complicated journey. And after 3 cycles, 7% bone marrow blasts. We decided to follow, because this was like a clinical trial protocol. The patient reached transfusional independence after 3 cycles. Unfortunately, after 5 cycles, complete remission with full hematological recovery, and an allogenic stem cell transplant was finally performed. After transplant, according to protocol, a FLT3 inhibitor maintenance was started with a good tolerability. However, the patient, he felt he was cured and he was okay, so he decided to return to his country, to Morocco, and we lose. This was a patient lost for follow-up. The last contact was in July 2019, and he was alive and in complete remission with the molecular MRD negativity. Hopefully the patient is still alive, but for sure he's not taking more maintenance therapy. So we have this is however a high risk situation, a FLT3 ITD patient in complete remission performing an allogenic stem cell transplant. There is a high risk of relapse. However, this is why there is a maintenance schedule in this clinical trial. And there are several strategies to prevent relapse in AML. Just keep in mind that relapse is the main cause of failure after allogenic stem cell transplant in AML. It is not GVSD or infections, it is relapse of AML. So there are different strategies like prophylaxis, maintenance therapy, for example, chemoprophylaxis, like in this clinical trial with FLT3 inhibitor, targeted therapy, but we can also give preemptive therapy. So if there is MRD positivity after transplant, or if there is a chimerism loss, we can then start some MRD-driven therapy with immunotherapy or with targeted therapy, for example. Also, we can, for example, use MRD assessment before transplant to define a high risk of relapse. So in this population that were MRD positive before transplant, we can have some protocol with some preventive measures to prevent relapse. This is an interesting manuscript by Craddock and colleagues, IBMTR series in patients with AML allografted, and they show that there are different prognostic factors defining relapse according to the time of relapse in AML. So in the first 3 months of relapse, the main risk factors was FLT3 ITD mutation. We know, and here is the proof, but we know that patients with FLT3 ITD mutations, they present early relapse frequently after an allogenic transplant. This is why, if there is some targeted therapy after allogenic transplant directed to FLT3 clone, these need to be started as soon as possible. If it is in the first 3 months, better than to start after 3 months, because as you can see here, there are many relapses in the first 3 months after transplant. However, it is challenging to start chemoprophylaxis in AML after allogenic transplant, as you know, because of drug-drug interactions and different comorbid conditions of the patients after allogenic transplant. It is important when we raise strategies to prevent relapse to know that there is, as well as I presented before, there is a clonal instability also after transplant, and this clonal instability can make, as in this study was shown, to have different patterns before primary AML before transplant and relapse. And also there is a clonal evolution in AML in terms of immune escape mechanisms. For example, loss of class 2 HLA has been shown as a main shift in molecular or phenotypic AML characteristics to avoid immunologic pressure after allogenic stem cell transplant. We can use targeted therapy. We can use also epigenetic modifiers to prevent relapse. I believe that this is mainly in the field of investigational strategies. So we still need to gather much more evidence to know better what to do with our patients. But of course, there is a need here, so intervention and in the context of investigational protocols is warranted. I will almost finish my presentation with the data from our institution. This is a retrospective analysis to show the burden of relapsed refractory FLT3 mutated AML. And this is a retrospective study, chart review study, and we see how from 3,400 patients, finally we identified 178 relapsed refractory FLT3 mutated patients. So this is showing the disease burden of relapsed refractory FLT3 according to all AML that is presented in one institution. And we found, as was expected, heterogeneity in the relapsed refractory approach. In the salvage, the first salvage, sorry, you can see like a FLAG-IDA in our institution was the main regimen, but also 20% of patients were not at all treated. And we see how in the second salvage, in the third line, almost 1/3 of patients were even not treated, and more heterogeneity, of course. And here you can see like how patients were included in clinical trials, 14%, and 6% in clinical trials with second-generation FLT3 inhibitors. And we can see here the outcomes of patients, relapsed refractory FLT3 mutated. In our institution, historical series, median overall survival was very short, around 6 months, 5.7 months, as far as I remind, and how different approaches gave different results. Intensive chemotherapy approaches, non-intensive here in red, only supportive care. This is more recent patients with second-generation FLT3 inhibitors. Of course, we cannot compare these approaches because there is a selection bias in patients that receive only supportive care or non-intensive therapies or intensive therapies. But what was clear is that to reach a complete remission led to almost 20% of overall survival after 5 years. And if an allogenic stem cell transplant was performed, the overall survival was almost 30% at the long term. So we do not have to give up in our relapsed refractory patients, even if it is FLT3 positive patients that with a dismal prognosis. And this is a proposed algorithm. This is an Iberian consensus that was published recently. And you can find this algorithm dividing in fit patients and unfit patients. Of course, clinical trials should be the first recommendation, but in fit patients, intensive chemotherapy. Now we have the possibility of second generation FLT3 inhibitors. Maybe the IDH inhibitors will play a role also in the management of younger relapsed refractory patients. And in unfit patients, we have medications of all the like, let's say, low dose RAC hypomethylating, hydroxyurea, but also with the eruption of targeted therapies, maybe we can offer something better to our patients. So thanks for your attention, and there is hope for relapsed refractory patients, and we need never to give up. Thank you.
Thank you so much, Dr. Montesinos, for the excellent talk and overview on the management of AML in this very hopeful time for improvement in the treatment of AML. Just a quick search on the ASH website. It showed 121 abstracts, oral and poster abstracts will be presented on AML and MRD assessment. So very hot topic and lots of research and progress in this field. For the audience, we have two questions will be posted. So please select the answers, the most appropriate answer that you think is correct from the screen. You can just click on the screen. So the first, these are questions from Dr. Montesinos, to see the audience responses. So FLT3 ITD positive hyperleukocytic and monoblastic AML patient showing bone marrow relapse 20% blast after induction with 3+7 and midostaurin. He had CR duration of 3 months. What's your preferred diagnostic workup? So please, we'll give a minute for this question. Should we move to the next question?
We can see the result.
So the results, so most of the audience selected the correct answer, which is cytogenetics and PCR for druggable mutations. So as shown in the presentation of Dr. Montesinos. So the next question, what's the prognosis for this patient? Okay, let's see the results. Similar prognosis. So most of the audience also selected the correct answer, which is poor prognosis, refractory relapse. All right, thank you so much. Now we'll move on to the Q&A session. We'll start with a question about your opinion about the Araki et al. Study. Why this study did not show a difference in the MRD eradication versus no in the benefit?
So
was there any like selection bias, or I'm sure like there are more studies
yes,
looking into the same question.
Yes. So the question is, in this study, why morphological leukemia had the similar worse prognosis than MRD positivity? I believe that this is the question. Yes, first, this study was not a huge cohort of patients, so there are numerical problems to interpret the data. Okay, but it was very appealing to put the curve of partial remission or active disease in the same position than MRD positivity. No, it was just a very, very nice finding. But with the following publications by other groups, there is a mitigation of these findings. So it is clear, and some studies have shown, in particular in thinking studies in pediatric patients, not only AML but also ALL, showing that there is an impact on the threshold of MRD positivity. It is not the same to have a 0.1% and to have 0.01%. And of course, I think that also this study was a single institution, but I think that the study of Araki, but I think that there is a major limitation in MRD measuring, in particular by multiparametric flow cytometry. There is an observator bias. There is no correlation between one physician and the other. Methodology is not very reproducible. Also the sample quality and the pre-analytical methodology, not only analytical methodology with MRD by flow assessment, is leading to many uncertainties. This is why I think that in fact there are some attempts in AML, and I am speaking about AML, because MRD in ALL or MRD in CLL or multiple myeloma is quite much more reproducible, and there is harmonization and it is easier to interpret. But in AML, there are, as you know, some attempts to incorporate MRD negativity as a clinical trial endpoint, and I think that it is really quite difficult. And if I was a regulator, I wouldn't accept this, because I know what are the results, what are the clinical implications and difficulties to standardize MRD assessment in AML. So I don't know if I really respond to the question of the manuscript of Araki, but this is my perspective on MRD in general in AML, and in particular before allogenic stem cell transplant.
Excellent. So another question from Dr. Farid Ahmed. Should we consider MRD monitoring standard of care in AML treatment and transplant?
This is a difficult question. I think that it is a good tool in order to predict the patient outcome. It is not a perfect predictor, not at all. Even MRD by molecular techniques like a real-time quantitative PCR, that in my opinion is much more predictable and reproducible than cytometry. Even this, it is not a perfect predictor, not at all. There are a lot of uncertainties yet. However, this can be a good tool, but the problem is what to do with MRD when you have the result. This is the real question. So my perspective is that MRD is a valuable tool that should be incorporated in clinical trials, and that should be incorporated in well-defined clinical protocols. So I will never recommend to use MRD if there is not a clear definition, a clearly defined algorithm, therapeutic algorithm in saying what you have to do with MRD. So if this is not protocolized, just don't use it, because otherwise you will put your patient and you will put yourself in troubles.
Excellent. Another question from Dr. Ali Gregory is, what's your acceptable MRD level before hematopoietic stem cell transplantation for relapse refractory AML?
Yes, this is very tricky. I would say that all levels in our institution, and also according to the PETHEMA protocols, that this is what we are following. We don't require MRD as a mandatory assessment before allogenic transplant, and it is not incorporated in the transplant eligibility workup. Okay, so I would say that morphological complete remission is the requirement for allogenic transplant, and I would say that knowing what is the MRD level before transplant, you can modulate immunologic strategies after transplant. So, for example, what we are doing in our institution is to define high risk, high relapse risk patients of AML patients with more than 0.1% of detectable by cytometry before transplant. Those patients, they will have a very rapid tapering of immunosuppression after allogenic transplant, and they will have tight monitoring of MRD after allogenic transplant. But this is defined by the protocol of transplanters in my institution. But I would not say to a patient that you are not eligible for an allogenic transplant because MRD is positive.
Okay, sounds good. From Dr. Ahmed Al-Askar, a question, how about other genetic mutations such as IDH mutation?
Yes. Look, my belief is that, and we have a lot of experience with IDH inhibitors in AML in the context of clinical trials. My belief is that these are very good drugs, IDH1 inhibitors especially, but also IDH2 inhibitors. They give an impressive complete remission rate, about 40% in the relapse refractory setting, and can be up to 50, even 60% in the frontline setting, as some trials have demonstrated in unfit patients in combination with hypomethylating agents. And in a proportion of patients, we can have durable and deep complete remissions. We have patients for 2-3 years with IDH inhibitors, and they were refractory to many other therapies before, and with the IDH inhibitor, they are in complete remission after 2-3 years. So this is quite very outstanding. The question is whether these new drugs could replace or complement intensive chemotherapy approaches in younger patients. We don't know. There are no data really, only phase 1, 2, and this should be very cautious when interpreting this. And unfortunately, in older patients, we have not very, very outstanding results. For example, there was in the front line, I refer, because the role in the relapse refractory setting, in my opinion, is clear. But in the front line, there was a trial recently published in abstract, azacitidine plus enacitinib versus azacitidine alone, and the overall survival was the same in both randomized arms. However, the complete remission rate was double in the experimental arm with the combination of IDH inhibitor and azacitidine, but unfortunately, overall survival was not improved. So in the frontline setting, for me, it is not yet clear what will be the use of these IDH inhibitors.
Sounds good. Question from Dr. Saud Barila. What's the prognosis and plan for Philadelphia positive AML in ineligible patient for allo transplant?
Yes. In our protocol, in the PETHEMA trial, it is not a trial, it is a guideline, okay? But the majority of Spanish sites are following this. The statement is to incorporate imatinib in these patients, and then to follow, it is a high-risk patient, of course, the Philadelphia positive, but to follow the same algorithm of treatment than other patients. Okay, so it's a high risk. Try to do allogenic transplant. If you cannot do allogenic transplant, just consolidate with high dose RC, with or without an autologous stem cell transplant, but always with a concomitant imatinib therapy. It is a relevant question because we are now analyzing the BCR-ABL AML in the PETHEMA registry, and it is almost 0.4% of AML. So it is a small subgroup, but it is not so anecdotal to have such patients.
Yeah, it sounds good. I think last question, because of the sake of time. So from Dr. Ihab Al-Hamidi, would you consider haploidentical transplantation in high-risk and favorable group compared to other types of transplantation?
Yes, absolutely, yes. But I can speak by my experience at my institution, okay? You know that transplant results are dependent on the site experience and site procedures and management. We were performing 10 years ago a pre-identical transplant with total T cell depletion. It was a quite very aggressive procedure with a lot of viral infection and transplant-related mortality. Now things moved incredibly better in the field of apre-identical since the advent of post-transplant cyclophosphamide. And in my experience, the best, of course, is unrelated donor, 10 out of 10 full matched unrelated donor, and after that haploidentical, and after haploidentical cord blood. Okay, but I would say that it is a good option for the patient that has not a full matched unrelated donor, but using cyclophosphamide, post-transplant cyclophosphamide, and in well-experienced transplant units. And the relapse risk, it is true that it is higher. We have about 35% to 40% of relapse, and of course more relapses in the unfavorable risk setting. But still, it is a procedure that should be offered under appropriate circumstances to high-risk patients.
Sounds good. Thank you so much, and thank you all for joining. Thank you, Dr. Montesinos, for the excellent presentation and the discussion. And thank you for SSBMT for the continuous education. This becomes as a weekly habit now every Saturday. So. Thank you, Astellas, for the support. Just a reminder for next Saturday of the next session will be on how I treat thrombotic thrombocytopenic purpura. And we have Adam Coker who will give us a talk on that night. So with that, thank you all for attending, and we'll see you next week.
Thank you. Thank you, everybody. Thank you, Dr. Pau. Thank you, Ahmed.
Bye-bye.